So we want to dive into chronic care management, the initiating visit. And we want to talk about when this initiating visit is required, what the documentation requirements are, etc. We will have an encore presentation available that will be after we get all the information back from our vendor. In addition to that, we also have an encore presentation from a webinar we did September 8th on chronic care management and the overview of that particular service. So that's the information that you can look at in an overview of the particular service. What we're going to talk about here today, and you can see on the agenda here, is really CCM. We're going to provide just a real brief overview on that. We're going to talk about when you need this initiating visit. We're going to talk about procedure code G0506. I think there's some confusion out there for the provider community as to when this particular service is actually used. So we'll talk about that. And then we'll talk about kind of what happens during this initiating visit and the information that you would share with your patient from this initiating visit. So again, just a real brief overview of chronic care management. One of the kind of confusing areas, I guess you could say, is that chronic care management, that particular term, includes both chronic care management, complex chronic care management, and then also principal care management. So when we're using that particular term, we will try and be as specific as possible to let you know which of those three we're discussing, or if we're discussing the entire program of chronic care management. So you can see there under CCM, or chronic care management, and complex chronic care management, this is available for patients with 2 or more chronic conditions. Now, the next bullet identifies information about those chronic conditions. They have to last at least 12 months, so either the patient has had it at least 12 months, or it is expected to last at least 12 months, or until the patient's death. In addition to that, the chronic condition is going to place that patient at high risk of morbidity, mortality, declined function, exacerbation, or death. For principal care management, this is when the patient has a single high-risk chronic condition. Generally speaking, there would have been some type of exacerbation of that particular condition. Maybe the patient was in the hospital, or the patient was at risk of going into the hospital. The condition here is expected to last at least 3 months, or until the patient's death also. When we're talking about principal care management, we're really talking, for the most part, not always, but for the most part, that condition will eventually transfer back to CCM or complex chronic care management. Now, that's not going to happen always. Sometimes that specialist is usually the one doing principal care management. Sometimes that specialist will keep that patient. What we're really looking for here is not where the patient is going to have care fragmentation. So we want all providers working together in doing the chronic care management services, regardless of which one you're doing, so that it is a patient-centered plan that's going on for that particular patient. We had a question from April on whether hospital outpatient departments can provide the CCM services following a hospitalization, and the answer to that is yes, when all the requirements are met. Clinical staff can provide chronic care management services, under the general supervision of a physician or practitioner. Hospitals working with these supervising physicians and clinical staff can take advantage of CCM in order to help reduce inpatient readmissions. We had a question from Susan on whether a practice could implement this for a small number of patients before opening up to all patients. This is your choice. Medicare can reimburse against CCM when all requirements are met. You would determine, based on the requirements, which patients are eligible for the service, and then you can determine to kind of start on a small basis with those patients you feel like it would be appropriate to do so, and then of course you can expand it as you continue to provide the service. You can find more information in the CMS Medicare Learning Network booklet on chronic care management, and we'll put that link in the chat function for you. CMS also has a question and answer document that goes along with CCM services, and we'll put that link in the chat for you also. Lillian had submitted a question on who can provide services. The chronic care management and complex chronic care management are generally going to be primary care practitioners, but not exclusively. The principal care management is generally going to be specialty providers, again, but not exclusively. Now, limited licensed practitioners such as podiatrists and chiropractors cannot provide the service. Marcia had a question on whether providers can do both chronic care management and transitional care management within the same month. And the answer to that was answered within our CCM overview presentation. And the answer to that is yes. You would just make sure that your documentation showed the complete separation of those services. So what is an eligible initiating visit? Well, these are listed for you on your handout, and then they're up on the screen for you. It is an initial preventive physical exam or the Welcome to Medicare visit, the annual wellness visit, an evaluation and management service, or the face-to-face service of the transitional care management. Now, in the document, the CMS document, it does not mention the transitional care management face-to-face service. However, this is listed within the 2017 Medicare Physician Fee Schedule Final Rule, and it's on page 80242. We will also place the link for that Physician Fee Schedule Final Rule within the chat function. Payment for these services, whether it's the Welcome to Medicare visit, annual wellness visit, etc., will need to follow the guidelines for that particular service, including the frequency. So the IPPE, this is done once when the patient is eligible for Medicare. Annual wellness visit can be done once a year. Transitional care management is after the patient has been released from a facility. And then, of course, we have evaluation and management services. Now, the CMS booklet, the wording that they actually use there is comprehensive evaluation and management. However, Medicare does not require a particular level of evaluation and management. Now, you can't obviously do this with, or initiating visit would not be the 99211 procedure code. That's for your clinical staff. But any of the rest of the levels of an evaluation and management service would be part of that. I do see that Dr. Vlahakis has joined us this morning. So we're going to pause just a second before we get into our next section and let Dr. Oaxacas introduce herself. Joelle?
Here, Ellen, I got all my technical difficulties straight away. Apologies to everyone. Thank you for your patience. So I'm Dr. Joelle Oaxacas. I'm new to the team, but not new to medicine. I'm an internist and a pediatrician who's been practicing palliative care for the last few years, and I'm very excited to be here. Thank you for having me.
Sorry, I had myself still on mute. So thank you, Dr. Oaxacas, for introducing yourself. Dr. Oaxacas will be part of the medical direction for the CCM project, and we talked about this in our last CCM overview webinar, which is that this is an innovation challenge that we have accepted, that we proposed, and CMS actually accepted. And this will be going on for the next year. So when is an initiating visit actually needed for a patient where you're going to do chronic care management? And as you can see in your handout and on the slide, you have to have one for new patients, and you have to have one for patients not seen within the previous year. Now, when we're thinking about this makes sense, because if it's a brand new patient to us, we don't have all the information, or you don't have all the information that you would need in order to develop a care plan for that particular patient. The same thing holds true if you have patients not seen within the previous year. You need to be developing with them what are all of their current conditions, what types of medications are they using, all of those things that go along with the chronic care management service. So for this initiating visit, in order for it to qualify as an initiating visit, and I'll bring up in just a minute why that's important, but in order to qualify for that, you have to discuss chronic care management. That has to be part of the documentation. And so you can see here on your slide, there's a discussion of what CCM is, how the patient is eligible for that, the fact that you think this would be a really good thing for your patient. You also need to discuss patient cost sharing. CMS does not have the authority to waive patient cost sharing for this service. Medicare allows anywhere between $48 and $125 for the service, depending on which of the services you're providing. The patient is going to have deductible and coinsurance for that. So as part of the conversation, you want to share that with the patient, that even though they may not have physically seen your physician or practitioner within that month, chronic care management is still going on, and they would still have that coinsurance. As part of the discussion on this, when you're discussing patient cost sharing, you want to let them know that the goal is for this patient not to have to go to the emergency room, or not to have to be readmitted to the hospital, or not to have an urgently needed encounter, face-to-face encounter with your physician or practitioner. Going to the emergency department, or especially being readmitted to the hospital, there's huge costs for the patient for those particular services. You also want to let the patient know that you will have staff available that they can talk to 24/7. So if they wake up at 3 o'clock in the morning and they're not feeling well, they take their blood sugar and it's either too high or too low, they can call this staff member, the clinical staff person, and say, okay, what do I do? That clinical staff person will have a copy of their care plan, and then we'll provide information back to that patient as to what needs to happen next. It could be, taking another dose of insulin if that's part of the care plan. It could be eating something, it could be exercising, whatever the situation might be. It could be telling the patient that they need to go to the emergency department. It's whatever that patient needs at that particular time. You want to let the patient know that this is a non-face-to-face service. So while there may be contact between the clinical staff and the patient, and that doesn't have to happen, but while there may be contact, it's not going to be a visit or possibly even not a direct contact from that physician themselves. You also need to tell the patient how they can revoke the chronic care management services if they choose to do that. And revoking that would be at the end of the month. And then the last two bullet points there, you want to have a conversation with the patient to verify that there isn't anyone else providing chronic care management or complex chronic care management. Medicare is only going to reimburse one provider for that. And so as part of that conversation, you want to make sure no one else is already doing this for the patient. Now, the patient may have an additional specialty provider who is doing principal care management, and that's acceptable, but you'll need to know who that is. The other thing that has to happen is that you have to have patient consent. Now, one of the questions that we've had on this is, well, you know, the patient has already signed an authorization so that we can release information to Medicare. Medicare can pay us. The fact that, you know, they have to pay for their costs going along with whatever services we're doing. Can't we just use that? And the answer to that is no. For this service, because it is a non-face-to-face service, you need to have that patient's consent documented within your medical record, and this would be separate from your administration records. So you can see here on your slide and in your handout, this consent can be verbal or written. It can also be gathered by the practitioner, or it can also be gathered by that clinical staff who are going to be involved with that patient care. The next thing that we have is discussing the comprehensive assessment and care plan. So we talked about the initiating visit, which are those services in E&M, annual wellness visit, etc., and when that has to happen. Documentation for those, again, is just like you would normally document any one of those services. This particular service, the Comprehensive Assessment and Care Plan, under that G0506, is an add-on to that initiating visit. And what this is the practitioner is performing a comprehensive assessment and is doing the care planning for that patient during that encounter, as opposed to doing that at a later time. So one of the confusions that we have heard about is that this procedure code, the G0506, is not the initiating visit. That's one of those other services. This is work because the patient needs a more comprehensive assessment, and that practitioner is developing that care plan at that time. We're going to discuss care planning within our next webinar, and we are in the planning processes of that right now. You want to watch our listserv for more information. This procedure code is not for your clinical staff. It is only for your physician or practitioner. You'll notice on the slide and in your handout, it is an add-on code to those other services. This can only be provided once when you're beginning chronic care management services for the patient. The other thing that will make this just a little bit more confusing and will rely more heavily on your documentation is there is no time attached to this procedure code. So what that means is that you don't have to spend a certain number of minutes in order to qualify for this code, but your documentation will have to support the comprehensive assessment and the care planning that your physician or practitioner did during that initiating visit.
Editor's note. We need to correct a statement made during the webinar. We apologize for the error. We stated you could not submit the initiating visit, the comprehensive assessment and care planning procedure code G0506 on the same day as the clinical staff initial CCM procedure code 99490. This is incorrect. The 2017 Medicare Physician Fee Schedule Final Rule on page 80246 indicates you can submit the initiating visit, the comprehensive assessment and care planning code G0506, and the clinical staff procedure codes 99490 and 99439 for chronic care management, or the procedure codes 99487 and 99489 for complex chronic care management on the same date or during the same month when documentation supports these services.
We have a kind of weird statement in your handout, and let me point that out to you. On page 3 of your handout, where did it go here? No, I'm sorry, it's on the top of page, no, it's on page 3 of your handout, sorry. And what it says in your handout is that you can bill this procedure code in addition to the monthly CCM service. I'm going to change the wording on that when we publish this handout for the Encore presentation, because really what this should say is billed in addition to the first CCM service, the monthly procedure code for that first one. This code is not available as you continue providing CCM for that particular patient.
Hey, Ellen, it's Mary Sue.
Yes.
We have a couple of questions that have come in the chat. And the first one is from Chris, and it says, does anything change if we provide a face-to-face service?
Does anything change with the chronic care management? We addressed this within the overview that we did, and there are certain services that some practitioners, because we ask them, some practitioners are providing face-to-face as part of their chronic care management service, and that can be included in with the minutes in billing for the CCM for that monthly service.
And your next question is, can a rural health clinic or RHC bill the G0506 at the initiating visit?
Okay, and thank you very much for that question. That is something we were going to discuss in just a second, but we can do it now. An RHC, Rural Health Clinic, or Federally Qualified Health Center, FQHC, cannot use this procedure code. They can obviously bill for the initiating visit as their encounter, but this procedure code is not available for them. Do we have any additional, Mary Sue?
That's all we have at this time. Thank you, Ellen.
The other thing that we want to make sure we're clear on in our education, and that you as the providers doing this are clear on, is this procedure code is not the initiating visit. That's all those other codes that we talked about. This is not automatic. You know, you have a discussion during one of those other visits about starting the patient on CCM, that's not this procedure code. The G0506 is a comprehensive assessment of that patient, and of course that would be documented, and then developing the care plan for that patient, and of course that would also be documented. So what do we do then if you have an established patient? Well, you don't have to have an initiating visit, but you do have to have a starting point. So in this situation, either you or your clinical staff would reach out to that patient, would utilize the patient's current medical records, and then you would start the care planning from that contact. The other thing that you want to think about is that, let's say that last month you had an evaluation and management service with the patient, but you didn't talk about CCM. So that would not be considered an initiating visit because you don't have documentation that you talked about CCM. But remember the requirements, you have to have an initiating visit for new patients or patients not seen within the previous year. Well, today you saw the patient last month. So the fact that you didn't talk about CCM during that visit does not mean that you cannot continue on and provide CCM for that patient. You would just need to make contact. You would need to start developing the care plan, all of those things that you needed to discuss with the patient during that initiating visit. You would just make that part of the contact that you had with the patient now. Okay, I think that information responds to two questions that Jessica had sent in. So Jessica, if they did not, then come into the chat and we'll see what we can do there. So that's the information that we have for you on the initiating visit itself. Just to kind of recap that, you have to have an initiating visit for new patients, patients not seen within the previous year, and that is 365 days. It's not a calendar year. So you have to have that initiating visit. You document during that initiating visit that you discussed CCM. And there's a whole list of things that you need to make sure are documented. The consent, providing patients with what CCM is, how this is going to benefit them, both for their health care and for monetary. Again, you know, paying for CCM for a year is going to be less than paying the deductible for a hospital inpatient. You have, you can take advantage of that G0506 procedure code when you're doing the comprehensive assessment and care planning. And then for your established patients, you don't have to have that initiating visit. You'll just make a contact with that patient and then start that with the information you're receiving from the patient and then also from the medical records for that particular patient. So Mary Sue, before we go in with additional information to share, do we have any additional questions?
Hi, Ellen. One question just came in on verbal consent, and the question says, verbal consent must be documented in progress note along with written consent, or basically does the verbal consent need to be documented along with the written consent?
You can have either one. Let's say for an established patient, you're not having a face-to-face with that patient. So you're talking to the patient on the telephone or you're exchanging emails or however you decide to do that. You need their consent in order to bill for CCM. So you can document within that patient's medical record, and it does have to be in the medical record, that the patient provided me with consent. So for an example, I could indicate, if I was the one doing it, I could indicate, I talked with Mrs. Jones on 10/13. She provided her consent to receive chronic care management services. I can put that in the medical record. If you have a written consent from her, let's say that she provides that either going through your portal, sending a text message, sending an email, whatever the situation is, then you just want to make sure that you can incorporate the fact that you have that written consent within your results.
And one more question. Can you have both CCM and PCM at the same time? Let's see, same time/month, but not same day.
A single provider cannot do both. So, you know, Dr. Jones cannot provide both chronic care management and then also principal care management. The patient can receive both. So the patient could be receiving chronic care management from Dr. Jones, but they're also receiving principal care management from Dr. Cardiologist. That's acceptable with Medicare. And as part of the care planning, Dr. Jones and Dr. Cardiology will be talking to each other. In addition to that, a patient cannot have both chronic care management and complex chronic care management within the same month. You need to look at those procedure codes to determine the differences between those two things. And then as the practitioner doing CCM, you would bill only one of those. Okay, any additional questions?
That is all for now. Thank you.
Okay, as part of what we're doing here today, we will be saving the chat function. We will be updating our question and answer document with the questions we receive here, with the pre-submitted questions that we have already received, and then also anything that's in the follow-up question module. We are sincerely hoping that you're sharing information within your offices, within your, with your physicians and practitioners, having those discussions. So if you do have additional questions, that follow-up question module will be open for 10 days. So the next thing that we want to do is just talk about some additional information to share with you. We have, as part of this innovation challenge that we talked about, we also proposed and CMS accepted a challenge on increasing the use of the depression screening benefit. We have been doing this one for a couple of years, this challenge, and we have really seen providers step up and provide this screening service to their patient. We've seen over a 50% increase in the number of services that we have received, which is fantastic. Another real big point of the depression screening is that we have also seen over a 10% drop in suicide attempts in our jurisdictions. This just really goes to support that the care practitioners and physicians are providing to the patients really make a difference in the patient's lives. That large of a reduction in suicide attempts for our Medicare patients is absolutely fantastic. With the chronic care management, we are also looking for similar results, although not for suicide attempts. But what we're going to be looking for is going to be less emergency room visits, less inpatient hospitalizations, because what that means then is that the patient's already being taken care of. They don't need to take advantage of these higher costing services. There is information available both in our Learning Center and in our YouTube channel on depression screening. We have all kinds of questions and answers out there. We have information on what this service is, how you can take advantage of that, the requirements for that. At least one, if not two, of our YouTube videos are actually where one of our contractor medical directors, Dr. Kettler, is responding to questions that providers have submitted. So it's a lot of really good information. We will be expanding the information we have out there on chronic care management as we continue through this challenge year also. Another thing we want to encourage you about, and CMS is really encouraging providers to provide the cognitive assessment and care plan for those patients who exhibit cognitive dysfunction during your encounters. Also in the chat function, we placed a website, a CMS website, where you can find more information on this particular service. Again, we've heard from multiple providers that when they're really doing this service, they're finding things that can improve the patient's cognitive dysfunction. And in some cases, I've heard from one provider that by really evaluating why the patient had this problem, they identified the patient had a urinary tract infection and had some medications that were working against each other. Once they fixed those two problems, the patient no longer had a cognitive dysfunction. Now, obviously, that's an isolated incident. Not all of your patients are going to, regain all of their cognition, but by doing the cognitive assessment and care plan, you really can make a difference for those patients. The other thing that we want to really encourage you to do is to take the surveys that we provide, not only for this course, but also for our website and for other departments. WPS wants to provide the best service to you that we possibly can. But in order for us to do that, we need your help. So we want you to let us know those things you think we're doing fantastic. That's really helping you to do your jobs better. On the other side of that, we also want you to let us know those things that we could maybe do better so that the service we're providing to you does meet your needs. So you can find the surveys available on our website, the different departments that have surveys going on. There's a survey link on their webpage. In addition to that, such as this function today, we will have a separate module that has a survey specific to this. You may also receive surveys if you have had a recent encounter with our medical review area, with our appeals department, with our provider enrollment area. We understand about surveys. We all get them through emails, through all websites we go to, whatever. But we really are interested in you taking just the couple of minutes that it would take to respond to that survey. So, we're saying please on that. So then Mary Sue will open it up. Do we have any additional questions?
Hi, Ellen. Yes, I have two questions for you. The first one is, I'm going to have you mute for a second. Perfect. Thinking about the 24-hour staff availability, what are some solutions for this? Does this mean a provider must be on call each day? We currently have an answering service that transfers only urgent after-hour calls through to the provider. Would that count?
That's a very good question, and we appreciate that. And no, that would not count. As we talked about within our CCM overview section, This 24-hour, 7-day-a-week availability of your clinical staff is one of the requirements for CCM. So I know the last time I contacted my provider office, the very first thing that came on there is, if this is an emergency, hang up and dial 911. That does not count for 24/7 access. The use of an answering service, which are generally going to be non-clinical staff, does also not fit within chronic care management. You need to have clinical staff who can listen to what it is the patient is telling them about whatever symptoms or problems or situation is going on, and can respond to that. Now, obviously, your clinical staff may not be able to respond to everything. They may need to contact the physician themselves. Depending on the circumstance, that clinical staff may tell the patient, hang up and dial 911. But the person answering that phone call has to be clinical staff that can address the patient's issues based on the care plan that has been developed.
And you have another question that came through. My providers are requesting a sample of a care plan. Do you know where I can find one?
There are places where you can go. CMS has a toolkit. If you go into the CMS website, which is cms.gov, do a search for care management, then the screens that came up, CMS has a toolkit out there that has information on some of the other organizations who may have developed templates for care plans, and also for ongoing chronic care management services. CMS has not developed one, and WPS at this time has not developed one. As part of the next webinar that we do, we are going to talk about what needs to go into the care plan itself. We will provide some of the resources on where you can find templates within the physician organizations. So Mary, we'll see one more time if we have any additional questions.
One additional question has came in, and it says, if the clinical staff responds to the non-clinical staff answering the call, and the provider responds to the non-clinical staff, then speaks with the patient, will that count? You might want to take a look at that question, Ellen.
Yeah. Let me scroll down here real quick. Okay. The situation that we have here is an answering service will not qualify. It simply will not. The person who's answering that call, and that could be a person such as myself, I'm not a clinical staff person. I would not have the knowledge or expertise in order to respond to that patient. Now, part of the question is, well, can I call the clinical staff people? Well, then again, we're not having that clinical staff work directly with that patient, and that's the requirement for chronic care management services. So your clinical staff and or your physician or practitioners, however you decide to do that, has to be available 24/7 to that patient. Now, we've talked to some provider organizations, and they have their directly employed staff that are available 24/7. However, they do that rotation. In some cases, they have hired care management organizations in order to answer those after business hour calls or contacts, because again, it doesn't have to be a telephone call. It can also be through a portal, through a text message, email, whatever it is. But for your patients, that you're providing chronic care management to, they're going to have a specific way to contact your office 24/7 so that they can receive assistance with whatever situation it is that they have. So having an answering service and having that answering service contact clinical staff or the provider, that would not count. Now, if your provider works directly with that patient, the provider contacts that patient directly, or the clinical staff contacts that patient directly, then that could count toward the minutes, but not when you're using that answering service staff as a go-between. That would not be acceptable. The other thing, and Mary, before we go on to anything else, the other thing I want to remind you of too, with any type of care management organization that you may determine that you want to work with, the person answering that phone call, text message, portal inquiry, answering that contact, that person must be within the United States. We've had a couple questions from providers that have hired entities that have staff in other parts of the world. That Medicare does not pay for that. We only pay for services that are being provided within the United States and the territories. But the person who's doing the service has to be within the United States. So any additional questions, Mary?
Yep, one last question. If all CCM staff nurses are busy with the patient on the phone and the call rolls over to the CCM staff voicemail, is that acceptable?
Yeah, it's just like anything else. If you have, Susie, who is the clinical staff working on CCM today, and she's responsible for answering that particular phone line or the contacts, if she's in the process of helping somebody else, or, she got up and went to get a cup of coffee, when she comes back, she's then responsible for responding to that person to that patient in a timely fashion. Again, you want to remember you're available 24/7 to that patient, so you don't want to simply put it on voicemail and call them back tomorrow. That is not acceptable, and it would not qualify for CCM.
All right. That looks like it is the end of our questions.
So that's all the information that we have for you to provide to you today concerning the initiating visit, when it's required, when it's not required, what can be the initiating visit, etc. So we'll go ahead and we'll end our presentation here in just a second. I want to encourage you to do the survey, to do the follow-up questions, to watch our listserv messages for future education that we're doing, and then also we're hoping to have that question and answer document out from the previous webinar within the next week. Once this closes, then we will work on adding those questions to that. So thank you everyone for attending, and you have an absolute great day.